Good afternoon, everybody. I hope you are all okay in Salzburg, because here in Kigali we are very fine, and I'm very happy to be with you this afternoon. I'm happy because it's a crucial subject, and I'm happy to dialogue with you and to exchange because it's crucial. The subject is, and I read, the promise of data, will this bring a revolution in healthcare? You have put a question mark, and I can tell you there is no question mark, because it is yes. Let's talk about in general. In all fields, we need information to know what to do, how to do it, how to measure what we do, so that we can improve. And in our sector, all this is data. And for Rwanda, the story starts around 2003 with the development of HIV program. We use money to design the type of data we need to follow people on IVs, to follow people after testing, to follow pregnant women after testing when they're HIV positive, and also for the period of pre-IVs, what will the child how we will follow the children born to an HIV-positive mother, and also the rest of the family. And since 2003, we have developed our system to cover all the major diseases. Now that we have a transition in epidemiology, we start to do the same with cancer and non-communicable disease, and we are developing a cancer registry. But what does it mean? For our healthcare providers, it means that they register each and every event, but they also need to register those events without duplication, meaning I'm HIV positive, I'm testing to test today, I'm registered in health facility A, and I'm shifting, going in another district, and I register now in a health facility B. They need to know that I'm the same person, and it's not two persons that are HIV positive. So we need accuracy of data, and we need really that those data reflect the reality of the country, so that healthcare provider can hand over the case to another health facilities where they left the case and the situation, and the patient has a continuum of care. Their family have a continuum of care. Secondly, what we need also is that healthcare provider can follow your evolution. You are in pre-IRV period. When should we start the IRVs? Or you have a cancer, you are on treatment. How are we going to follow you during the post-treatment to be sure that you are cured and you don't do another episode of a cancer? Knowing also that people who have got a cancer have predisposition sometimes, according to some cancer, to do another one. So how to identify the portion of our population that needs special attention, special prevention, and also a special treatment? All those are data. So what we did, we have between 2004 and 2008, we create a system across our health facility where people were reporting manually. And when internet has got a very good penetration, all the reported of all those epidemiologic events, they were reported manually. And when internet penetrates the health facilities in Rwanda, they were sending monthly their report to the central level so that we can aggregate and understand where the country is going. And I can tell you that this is very important, because since 2004, we can compare the evolution of disease in Rwanda, and we can register now that we have an increase of malaria, that we try to find why. That's how we saw that we are victim of the global warming. victim also of resistance to drugs, and also that we had fake drugs, and also not fake drugs per se, but our bed nets were substandard, not really well impregnated with pediatrium. We so discover the situation of malaria using the data that are collected regularly in routine at all our health facilities. We react, and we saw with using prevention method and spray how the malaria cases decrease. So it allows us to measure the reaction and to see that the money we have invested in this reaction is well placed because the cases of malaria decrease. We have other data that we need to manage our health sector. We have a system that records the number, the qualification of health workforce at health facilities at all levels. That's how we can see, if we compare to the census, if the number of doctors are equally distributed across the country. This is a matter of assuring access to care and equity. That means using those data allow us to fulfill our mission to provide equitable care across the country. And of course, we are not a rich country, so we don't have enough workforce, but our job is to distribute them in an equal manner. We have also a system of alerts. We have what we call rapid SMS using by phone. And if you remember, because we have presented that several times, we have a pyramid of care with reference and contra-reference, with 3 community health workers in each village. Around 10 villages make a cell. We have a health post with a nurse. Around 5 to 7 cell make a sector. We have a health center with several nurses, around 14. And 7 to 10 sectors make a district, and there we find the doctors. All this chain collect health information, I told you, on epidemiologic event, the quality and the quantity of health professionals they have, but also on emerging epidemic. Like we have some zone where we have cholera. We always block any epidemic because we have a system on alert by phone. Using the community health workers trip a village in all zones at risk. Any suspect diarrhea is announced immediately, timely, to the central level, and we send a team there from the national lab, and also to put people on isolation, to reinforce sensitization in the village, and to give them what it takes to make the water safety for them to use. This rapid SMS has even allowed Rwanda to block an epidemic of cholera in one refugee camp. We are the only country who have made it rapidly before reaching 15 cases. I want to recall how dangerous are cholera epidemic. Remember Haiti. They have more than 10,000 deaths today due to an epidemic of cholera that was not blocked at the beginning. So we have the rapid SMS. We have also the rapid SMS that alert us when somebody across the country needs an ambulance through the community health workers. You know, a village is 50 to 200 houses. So if somebody needs an ambulance there are 3 community health workers. Any of them can call an ambulance using an SMS. The SMS is sent to the district. We receive also a copy, and the district send an ambulance. We can cross-check if the ambulance went. We can also cross-check if there is no abuse and if all the people in need are served. It allows us also to see if the distribution of ambulance serve in equal manner the population. So on top of the health professionals, the epidemiologic event, the rise of acute epidemic, we have also the management of drugs. From the central level to each health center, we have the drugs enter in the country for the public sector, the drug use by the patient, at which level, and we know what we have to procure. It has helped us to avoid stockout and to be paperless. Because, you know, when you have 50 pages of reports to read for all those information, we don't have the personnel for, and we don't have the time. So the electronic way we are working, paperless, help us to deliver the service on time. Avoiding stockouts allow us to provide better care. We have other information system, the equipment that we distribute across the country. It allows us to follow the equipment, to follow and to assure that the preventive maintenance are done, and also when some equipment are broken, to see and to follow if they are repaired correctly and by whom. We have also the facility themselves that have a code. We have each health professional that has a number. So if I want, I can even see which health professional prescribe too much of some drugs that are used by people that are drug abuse. And also to control and to see if there is not overuse in some places in the country. So it allows to regulate the circulation of drugs. We have also our health insurance that is recorded from the sector up to the central level, with each and every one having a number. We have also the performance-based financing that allows us to see the performance of each health facilities, and you know that we pay, everybody got the salary, every health facility got its allocation of funds, but on top of that, for good service rendered, we have what we call performance-based financing. We send money to health facilities. Portion of that is a take-home for the personnel. A portion of that is for beautification, maintenance of equipment, etc., or to do something the health facility needs to do. And this money, on top of the allocation for the health facility and on top of the salaries, is money that the health facility receives for providing good quality care in a certain quantity. For this also, we have a system to manage it. But the most important now, all those systems have to talk to each other and share to one platform that is easy and friendly to manage. And this is what we call interoperability. So all those data allowing us to see which health facility is concerned, how many personnel they have, what happened with the drugs, which type of diseases they face, if there is an epidemic, how the equipment is maintained, etc. We have 13 software that allow us to manage the health facilities. And with a platform that is interoperable, all the districts manage their own, and at central level, we manage the entire country. We can, with this, provide better care. That if we have only data, that are fragmented, paper-based, time to read the report, we are out of date, they're timely. We can manage the country and assure the quality care our people need, inside the means we have. Many people ask how Rwanda got so good health indicators. I tell you, it's because we use the data. It's not only important to collect the right data, to send them in the right place, to use them, but also to analyze them to do better. So, once again, I tell you, collecting data in an accurate manner, analyze them, allow us to provide better care. And also, when you don't have data, you don't manage. When you don't manage, people are just lucky that you do the right thing. And there is another sentence I love, is, in God I trust, to all the others I ask data. Good afternoon.